Good morning, and thank you so much for the invitation to speak. I actually, I live in Brooklyn, adjacent as we call it, which is Philadelphia. I'm a Northeasterner. I grew up in Rhode Island, and essentially feel like I followed the Amtrak train line. So I was in Providence, then Philadelphia, then DC, then Boston, New York City. I did a chapter in Denver, Colorado at the University of Colorado, and then I was recruited back to Philly. And I was just telling Nympha and I have known each other because of the emergency medicine and point-of-care ultrasound world for years, that it made me realize how much of a Northeasterner I really am, and I really do think that Philadelphia is Brooklyn-esque and New York City adjacent. By a show of hands, how many of you are emergency medicine residents? Okay, so the majority. How many of you are emergency medicine attendings? Great. How many are trauma surgery attendings? Okay, thank you. I heard you were in the audience. And you're attendings?
Yes.
Okay, great. By a show of hands, how many of you are familiar with the FAST examination? Should be 100%. Okay. How many of you use the FAST examination regularly in your practice? Yeah, okay. And then my trauma surgeons, are you performing the FAST as faculty?
Yes.
Okay, and your residents are learning it?
Yes.
Okay, so one of the things that I've seen, and one of the impetuses for talking about the FAST exam, because people are really the FAST, like we already know how to do the FAST, is where we are today in 2019, because where we are today is a little different than when I was learning it in 2001. And actually, we're going to go through some of the history of point-of-care ultrasound and the FAST to understand where we are today and really where it should play a role in our patient care management. So you're going to see in terms of my slide style, I really like icons, and so this is a FAST. Okay, so 3 take-home points. Number 1, the FAST examination does not replace CT. It does not equal CT, it does not replace CT. And we'll give context to that. But a lot of times people say, okay, the FAST is negative, no need to CT. That's not 100% true. It's not 100% how we should think of the way and the place that point-of-care ultrasound, the FAST exam plays when it comes to patient management in blunt abdominal, thoracoabdominal trauma. Number 2, the FAST exam, it provides data, a data point. And as we all know, what we do, the nuance of what we do as compared to, say, the Department of Radiology with a technician, is we're taking history, we're performing physical examination, we're interacting with the patient at the bedside, we're performing our FAST examination, it's providing us data, we're obtaining images, answering questions, integrating our interpretation into the patient care, into the patient in front of us, and from there we're making decision making about ultimate disposition or further testing and management. It's a data point, and so I really want you to think about the FAST examination as a data point. Finally, there's a very positive aspect of the FAST exam. It decreases time to definitive management. Whether that definitive management is the operating theater, as I like to say when we're in the UK or in Australia, whether it decreases definitive management to the CT scanner, whether it changes definitive management with getting your consultant involved. The FAST examination decreases time to definitive management. Okay. What does the FAST stand for? FAST is an acronym. Who can say what the FAST stands for? Focused Assessment of Sonography and Trauma. Now, there's a caveat. FAST did not always stand for the focused assessment. Anybody know what it originally stood for? The A, rather than assessment, stood for abdomen, because that's what the original indication was. So we'll talk about where that was and where that played a role. But first, we're going way, way, way back in time to the 1790s. Lazzaro Spallanzani, he was a priest, he was Italian, and he was a naturalist, and he particularly liked taking hikes at night. And he's credited as the first for appreciating that bats communicated by echo, by sonar, by echolocation and sound waves. Moving ahead quite a few years, we have a Swiss physicist, Jean-Daniel Collandon. He conducted a key experiment on Lake Geneva in Switzerland. There was a church bell that got submitted underwater. They hit the bell and caused vibration. They did the same exact exercise in the air. Lo and behold, they found sound travels faster in a liquid medium. Moving ahead 50 years, we have the Curie Brothers. Pierre was the one that was actually married to Marie Curie, who we've heard about. The Curies are credited as discovering and describing the underlying physics concept of ultrasound. Now, at the end of the day, most of us really don't love the physics. In fact, as an educator, it's kind of a bummer when you're the one to give the physics exam because it's really hard to make it spicy and saucy and nice and fun. But the underlying physics concept is something that you already get whether or not you've thought about it. It's called the piezoelectric effect. Piezo meaning pressure, electric, electricity. And here's the underlying concept. Before the butterfly came on the scene with the microchips, every single probe that you held, and the reason why they're so expensive and they break, and you sometimes get a line across the screen where your sector's out, is because they have crystals. These are quartz crystals. They're aligned at the head of the probe, and if you actually cut open a probe, you'd see all these crystals. Electricity causes these crystals to vibrate. That vibration sends out a sound wave in a liquid medium. The machine sends out those waves, and it's listening back for waves to return once it's hitting an object of interest. The computer portion of your ultrasound machine translates those returning echoes, and we get a beautiful image on the screen. Bless you. And so that is the piezoelectric effect. And that's why we're able to use a probe, add some gel, put it on the body, get an image, and see something on the screen. Now, moving ahead some more years, Paul Langevin, he was a postdoc in the Curie's lab, and he was particularly distressed at the sinking of the Titanic. He didn't want anything like that to happen again. So he's credited as being the first to describe what he called at the time a hydrophone, which was a transducer. And using the technology that he created, World War I submarines were able to navigate around icebergs. Now let's get into some medical. Karl Dusick was an Austrian neurologist, psychiatrist. It used to be one residency training, not two. And he sought to use ultrasound in medical applications. And he's credited as the first to use ultrasound to try to discover and describe brain tumors. And here's a black and white photo that shows Dr. Dusick on the right. You can see the patient is lying with head right up near the machine, in the machine, and there's ultrasound using to describe and visualize brain tumors. Bring it to the United States, George Ludwig was an internist at the Naval Center in Bethesda in the 1940s. And he's credited with describing A mode. Does anybody know what A stands for? My non-ultrasound people? A stands for amplitude. And this is one of the first modes in ultrasound that was utilized. And we really don't see it much today. The one specialty in which you may see it is ophthalmology. A stands for amplitude. And what we see is, on the x-axis, you have the distance that the sound waves are traveling before they hit an object of interest. The amplitude, or the spike on the y-axis, the vertical, is the intensity of that sound. So you can imagine if there's a probe on the body in the right upper quadrant, and you're trying to describe gallstones, which is what he was using this amplitude mode for, if you were to hit a hyperechoic stone, you would get an amplitude spike. Moving ahead to B mode. B mode is what we're most used to. It's sort of the it's sort of the basic mode. B stands for basic. B, I remember as going back to the beginning, it's the 2D mode that we're most used to seeing. This was first described by this team of nephrologists, radiologists out of the University of Colorado. Now, one of the limitations was, obviously this is an icon of a patient in a bathtub, but it was this concept. The patient had to be exquisitely stable and mobile and actually sit in a bath of water. And this is also to illustrate where we've come in terms of the patient having to be submerged in water versus now we have these portable machines and handheld machines connected to our iPhones right at the bedside. This was a duo from Sweden, and they were a cardiologist engineer, and they were quite distraught at patients who were getting endocarditis and rheumatic heart disease. And actually the patients were presenting in sort of too far down the road before any of the disease could be prevented or picked up ahead of time. So they utilized some of the technology of ultrasound to describe modern echocardiography. Ian Donald was a professor of midwifery in Scotland, and he was accredited as being one of the first to use ultrasound to apply for women for OBGYN applications. So that was just kind of walking you through where we were, what is ultrasound, how to get the physics of ultrasound, applications non-medical, applications medical, different modes, to 1971. In 1971, we see the first case series published by interventional radiologists. The title of their paper was Ultrasonic Scanning in the Diagnosis of Splenic Hematomas. So this is one of the first papers to talk about the use of ultrasound for blunt injury. 1979. Anybody know what happened in 1979? This was the year that emergency medicine became a specialty. So you can see the buildup. We're getting to medical, we're getting to ultrasound, we're going to get to point-of-care ultrasound and use in abdominal trauma. So in 1979, after a few applications that's very common for a lot of the specialties under the ABMS umbrella. ABMS is American Board of Medical Specialties. All the different specialties in medicine, emergency medicine, just became a specialty after applying a few times in the 1970s and 1979. So what else was happening? Well, late 70s, early 80s, we're starting to see the advancement of technology. We're starting to see home computers. They're getting smaller. They're now placed on the desktop. And in fact, in the 1980s, it was the first time that I had a computer, and I had like a Mac SE, and it sat on my desk, and it was what my friends and I were using to write our papers. Also in the 1980s, we start seeing the use of ultrasound by trauma surgeons in other parts of the world being described, and sort of what would become to be known as the fast exam. So the use of ultrasound in blunt trauma was first starting to be described in Japan and in Europe, specifically in Germany. So now we're in the 1990s. And as was introduced, I was in college. I graduated college in 1992. And this was before you actually had to do research to get into med school. I was trying to figure out if I even wanted to become a doctor. Nobody in my family is a doctor, and I thought, well, I should start just observing in the emergency department. So I was working with an attending who said, do you want to do some research, like clinically based research? And I said, okay. So at the time at Rhode Island Hospital, there was a big transition in the treatment of trauma patients. They were having every single patient get a DPL and stopping that practice and moving them to having a CT scan, because this is around the time that hospitals were starting to place CT scanners in the emergency department. So this is also around the time that I sort of was starting to learn the language of medical, and I remember actually practicing DPL, diagnostic peritoneal lavage, because I had no idea what the words meant. But what I was seeing in the early 90s was this transition of how blunt trauma patients were being managed. Now, one thing that may not be known is in the early 90s, the first people in the United States that were using ultrasound machine in trauma were surgeons. They were trauma surgeons. And this woman, Grace Rosicki, in 1992-93, at a bunch of the trauma proceedings, she was the first to describe the FAST. And at the time, the A stood for abdominal, so it was the focused abdominal sonography for trauma. And she was at Emory at the time, and she actually has published quite a bit on this. Surgeons and surgeon-performed ultrasound in evaluating blunt trauma patients. And very interestingly, she did a prospective study. There were about 200 patients, and her sensitivities and specificities in the early 90s matched what you're going to see in terms of the numbers that we see in a 2018 Cochrane review. So she was right on, they were right on. And certain things that she established is, number one, physicians can perform the FAST exam. Number two, they're actually quite accurate, and their sensitivities and specificity, the numbers then are similar to now, and you have to understand where to integrate that information in your patient care, going back to the FAST exam as a data point. Now, we all think of point-of-care ultrasound and the FAST exam as being the house of emergency medicine, because really, in the United States, point-of-care ultrasound has really taken off and really gotten established and really had lots of its published literature because of emergency physicians. So these 3 women at the University of Wisconsin in Milwaukee were the first 3 to ever complete a point-of-care ultrasound fellowship. They're emergency physicians that did ultrasound. And Mary Beth Fellon is actually still the division director in Milwaukee. So we're moving through the 90s into the early 2000s, and we're starting to see a lot of published literature. We're seeing policy statements. We're seeing a call for standardized training from SAM, from ACEP, the American College of Emergency Physicians, AAEM is jumping on board, and we're starting to have some of those first people doing ultrasound writing position papers and actually coming up with the core content of emergency medicine. 2001 is when we first see the core content of emergency medicine say ultrasound, and this is around the time that program directors are trying to say, this is great, we think our trainees should know it, you're telling us they should know it, who's going to teach them, how do we teach them? Now there's a lot of literature that covers the next decade, and I'm by no means going to walk through the literature because we all know that's has a limited stimulus for our brains at this hour. But what I want to highlight is a few important studies that bring us to where we are right now in 2019, so you can understand where the FAST can play a role in your patient care and which patients it has more of an impact and the sensitivity and specificity is higher versus other patients. So in 2006, there was the SOAP study. This is Larry Melniker from Methodist, came with this study, and it's a very long title. I'm going to read it. Randomized Controlled Clinical Trial of Point-of-Care Limited Ultrasonography for Trauma in the ED, the first sonography outcomes assessment program trial. So this is the SOAP trial, and we're planning on having more SOAP trials. So this was about 300 patients, and it was multi-center. And what they did was patients came in and they randomized them. They got their regular trauma workup and care, and or they got their regular trauma workup and care plus ultrasound performed by an emergency physician. And in terms of their outcomes, the biggest thing, as they showed, is use of ultrasound in these blunt thoracoabdominal patients decreased time to the operating room, decreased time by 64%. Now, secondarily, they did report that it decreased cost, decreased days in the hospital, decreased number of CT scans, but really what the study was powered for was it decreased time to the operating room. And you remember take-home point, we talked about it decreased the time to definitive management, and that's exactly what the SOAP trial showed. This is also considered a big win at the time because it was in Annals of Emergency Medicine, which has the highest impact factor in our emergency medicine journals, and it was prospective and randomized, which in terms of sort of the quality of research, that's sort of the best you can get. And for those of you that sit and exhaustively read the ultrasound literature, they all start out with a case report, then it's a case series, then it's a retrospective chart review, then it's a prospective convenience sample, and in fact, most of our studies are prospective convenience samples, because it's when we're conveniently in the ED to enroll patients, because it's really, really hard to perform prospective, randomized research in the emergency department if you don't have everybody vested interest, and if your emergency department patient care isn't set up to be able to enroll patients. It's hard, and that's why most commonly it's prospective convenience, and this was a prospective randomized, so this was a big deal for those reasons. Now, it wasn't until 2013 that we actually see the FAST exam and ultrasound show up in ATLS training. So it wasn't until 2013, the 9th edition of ATLS, that we finally see ultrasound showing up as a skill station. Meanwhile, DPL, even though it was no longer really being practiced, it was still being taught. In 2013, finally ATLS said, you know what, you should have a FAST skill station, and it's optional if you want to have a DPL station. Now, this is a selective sample. How many of you have seen a DPL? And how many of you have performed a DPL? Great. So this is actually, there were about 4 or 5 hands up. You have seen a procedure that many, many, many emergency medicine trainees and very many emergency medicine attendings have never performed, and they probably just saw. Because again, of this movement in time from DPL to CT, CT to ultrasound, it also depends where ultrasound really took off. Developing world, disaster situations, limited resources. And when I was learning ultrasound, when I decided to do a fellowship, there were 3 people that I knew that had done ultrasound. This is in 2001. One person did a lot of global health work in Africa. One woman did a lot of disaster management in Kosovo and in Africa, and the third had trained in the US at LA County USC in the 1980s. So the places that we see ultrasound, the early adopters, it was basically county hospitals, inner city hospitals, places, and actually rural settings, places where there are limited resources and you couldn't just get every CT scan, every MRI that you're aware is available at some of the tertiary care and quaternary care places. So just really interesting time-wise, because also you remember 2001 was when it was first in the core content of emergency medicine. It takes a long time. And one more side note, if you are into reading the literature, and I actually didn't get into reading the literature until I had time to read the literature. When I was in residency, I was just trying to do my shifts and read my emergency medicine textbooks. But once you become sort of selected into a specific subject matter, you start getting to know that literature. And what I've seen now with ultrasound and taking on leadership positions is a lot in the business world literature, like Harvard Business Review, Wall Street Journal. These type of articles are often very relevant to what we do in emergency medicine. So in 2001, there's a Harvard Business Review that talked about the integration of technology. And Silicon Valley and non-medical situations, technology, once it's proven to be true and safe, it gets integrated. We in medicine, we are slow. We are slow, and there are a lot of us that are conservative. Now, I don't think emergency physicians, we don't consider ourselves conservative, but the House of Medicine is pretty conservative. And it's very slow to get an established technology integrated into patient care. And the Harvard Business Review talked about, on average, it takes 15 years. So here we are, 2001, it was established as a technology that's safe, accurate, and we should be learning it. 2013 is finally where we're seeing it in ATLS. Back to the highlights of specific articles that you should know. So we have the SOAP trial of 2006. 2017, this is a very important prospective randomized trial. The effects of abdominal ultrasound on clinical care, outcomes and resources use among children with blunt torso trauma, a randomized clinical trial. So this was published in JAMA by Holmes et al. And this sort of came at the time that a lot of people who take care of kids, specifically trauma with kids, pediatric trauma centers, etc., they started really questioning the role of the fast exam and ultrasound, because we thought this is the holy grail, this is going to save everything. Kids aren't going to have to get radiation anymore, we're going to decrease CT scans, but a lot of people were finding a lot of questionable data and having a lot of missed injuries in children. So this group of authors decided to study it. So there were about 1,000 patients enrolled. One of the limitations is that it was a single center. One of the other things I'll say is their inclusion criteria were very limited. These kids had to be very, very, very healthy and very, very, very stable. That being said, their data was pretty compelling. Their conclusion, which I'll read there, is that the routine use of the fast examination in hemodynamically stable children with blunt torso trauma may not be useful. So this was, again, this really goes against what we're taught, because for many of us, fast is the first application, it's sort of your bread and butter, it's where everything comes from, and we're led to believe that this is tried and true. But the reality is, in the pediatric population, it's not as compelling. The data, the specificity and sensitivity aren't as high as we're seeing in adult patients. So the results of this study is that the fast examination actually did not decrease time, did not decrease the number of intra-abdominal injuries, and didn't save any money for this patient population. Now we talked about the Cochrane review. Is everybody familiar with Cochrane? Yeah, I mean, it's powerful, it's impactful. What they come out with is usually very rigorously done in terms of meta-analyses. So there was a Cochrane review in 2018, point-of-care ultrasonography for diagnosing thoracoabdominal injuries in patients with blunt trauma. Now, a review of some terms, and I do this a little bit more for me than for you. I always have to remember the definition of sensitivity and specificity. What's this really telling me? What's this number? So as a reminder, sensitivity is the ability to detect a person with the disease. Specificity, the ability to exclude a person without the disease. So this Cochrane review in 2018 looked at all potential studies. Those that met their inclusion criteria were 34 studies. They had a conglomerated number of about 8,600 patients. And these are the numbers. The use of the fast exam for thoracoabdominal trauma, about 96% specific and about 74% sensitive. These are almost exactly the numbers that Grace Rudicki had with her surgeons in 1992. They split this out to look at kids, and what they found is both the sensitivity and the specificity were less, 91% and 63%. What about the big E, the elephant in the room, meaning the EFAST exam? Because we know that above the diaphragm, ultrasound is actually quite good. So when we're talking about the EFAST, because in the mid-2000s was we started seeing described not just the FAST, but the EFAST. E stands for extended. And what I generally think of as extended above the thorax. And for those of us that are in the administration and business part of ultrasound, the other reason why it gets divided up is for coding and billing. It's a different procedure, cardiac, thoracic, abdominal ultrasound. So we end up starting to think about it that way. Just because, again, that sort of business ends up playing into how you're administrating some of your medicine. So when it comes to ultrasound for evaluation of pericardial fluid, thoracic fluid, and pneumothorax, our sensitivities and our specificities are much, much higher than as compared to X-ray and as compared to other means. So very high specificity, very high sensitivity. And this, I think, shouldn't be surprising to many of you. Now, we've noticed, again, when we bring all the numbers together, the thoracoabdominal sensitivity is low. What are our opportunities in the trauma bay, in our resuscitation room, to increase the sensitivity? Well, these icons are supposed to let you know how we can do it. There was a study early on in the 90s that talked about Trendelenburg. And I find like it's not as well documented, not as well known. People aren't repeating this, but this is a really good study because they talked about if you have your patient who's flat, your trauma patient, if you just put them in 5 to 10 degrees of Trendelenburg, you're going to increase the sensitivity of your FAST exam. Why is that? The pelvis, like the pouch of Douglas, is your area that is the deepest pocket in a supine patient. But why do we always think it's Morrison's pouch? Well, the reality is the organs that bleed are the spleen and the liver. And where do most patients get hit, say if they're driving a car? In the upper abdomen. So the reason we always go towards Morrison's pouch is because that's where people bleed, and that's sort of mechanism-wise, unless we know that it's a crushed pelvic injury, that's where we go first. You don't have to go first, but that's where most of us go first. So if you want to increase your sensitivity, put them in Trendelenburg, you'll have fluid go up the paracolic gutters, you'll see fluid in Morrison's pouch. That middle icon is like an agent, so I think of a contrast agent. There's a lot of literature that's come out and a lot of medical centers that are doing research that are talking about the use of bedside. You like that? I know, it's ridiculous. Agent, contrast agent. So, it's good, I love icons. Anyway, contrast agents and the use of contrast agents is actually becoming popular, specifically in centers that are very fashion forward regarding their ultrasound research. We're seeing this at pediatric hospitals. Aaron Chen, who's at college at CHOP, Children's Hospital at Philadelphia, they're doing that. This is different than the contrast experiments that are being done in radiology suites. These are specifically trauma centers when they're doing it. And by injecting very safe, water-soluble contrast agents, we're increasing our sensitivity. Finally, repeat. Now, many of us know that if you evaluate a patient at time 0, and all of a sudden their blood pressure drops and their heart rate goes up, repeat the FAST exam. Now, when I was training, I trained at the 4-year program, the Brigham Mass General. Boston is a relatively safe city, and you're not seeing a lot of trauma. You see a lot of blunt trauma and a lot of drug driving, but not as much trauma as some other cities. So I decided in one of my electives that I really wanted to see and get bread and butter, recipe, protocol trauma so that I really just would get used to it. So I went to Ryder Trauma Center in Miami, and I saw lots and lots and lots of trauma, both blunt as well as penetrating. And they actually were very progressive at the time. So this would have been in 2000, where every single patient that came in had a tech come in and did an ultrasound right at the bedside. They'd say fast negative or fast positive, and that was it. So that's not a model many of us have, but it was the model they had set up. So it was not the trauma surgeons, and it was not the emergency medicine residents. They had an ultrasound tech that came in, performed it right at the bedside, called out the results, and left. So when those surgeons had very, very, very low suspicion to begin with, that maybe they wouldn't even have done a FAST exam, that was just part of the recipe, part of the protocol, if that was negative, the volume of trauma patients, everybody couldn't get a CT scan. They really sort of were clear and thoughtful about their diagnoses and about their testing. Those patients would wait sort of lined up in the hallway, and 30 minutes later, up to 60 minutes later, all those patients had a repeat fast. So when there was low suspicion, mechanism not concerning, patient stable, fast negative at time 0, 30 to 60 minutes later, they repeated the fast. If still 0, still no concerns, they discharged those patients. So it was very good for me to see that integration and to see, because there's no one way and there's no one-stop shopping. And that goes back to the point about fast is a data point based on what we're seeing. So never underestimate the power of repeating the fast exam, and when the vital signs change, you definitely should repeat the fast exam, because negative fast becomes a little accumulation of fluid. 30 minutes later, positive fast with accumulation of fluid, that's going to decrease your time to definitive management, whether it means stat to the CT or high enough mechanism decision making with your trauma surgeon that you take them to the operating theater, because I like to make them British. Okay, so the summary of the Cochrane review was fast negative. You have to send them to CT scan, but you don't have to. Again, if your fast is negative and your suspicion is high, don't stop there, because of the sensitivities and the specificities found with the 8,600 patients. If you're concerned and there's blunt thoracoabdominal trauma, you should get them to the next imaging modality. What about penetrating trauma? So it's very obvious if there's penetrating trauma above the diaphragm, it would be obvious that we could see fluid around the heart, fluid in the pleura, pneumothorax. But the role of ultrasound in penetrating abdominal trauma has been really questioned. In fact, when I was at St. Louis Roosevelt, I was there for 12 years. Whenever we wanted to fast the penetrating, they actually yelled at us. They were like, "Don't do it. There's no role for ultrasound in penetrating trauma." Now, we understand there's a nuance and there's a spectrum. You know, there's the element of it's a learning exam. You know, it's good to just do it routinely for the protocol of trauma. But actually, there is a role for ultrasound in penetrating trauma. When we did actually a review paper on the role, and the papers obviously were more compelling for above the diaphragm. Below the diaphragm, though, there is literature to support. And in fact, in the Journal of Emergency Medicine, there's a publication about the slow exam. So obviously, fast, slow. Slow is another acronym, systemic sonography for occult wounds. And this is a very interesting study. Basically, there's a podcast on this too, that basically there is a role, and similar to if you know how to do an ultrasound to evaluate for small bowel obstruction, where you do a little bit of a lawnmower effect, you can do a slow focal evaluation at the site of the penetration of the penetrating trauma, and there's evidence to support that you can find occult wounds and pockets of fluid. And those pockets of fluid will often look geometrically shaped surrounding bowel, and those can play a role, because think about if there's a gunshot, or specifically if there's a stabbing. If you're seeing fluid, that could be fecal material that's now poured in the peritoneum, and you can pick up this sooner rather than later, and again, go for that definitive management, whether that's it's exploratory laparotomy, definitive antibiotics, again, consultation and conversation with your specialist. That was quite a ride through history. Take-home points from this lecture. Where are we with the FAST examination in 2019? Number one, the FAST does not equal a CT scan. If your FAST is negative, you have to determine observation, CT scan, operating theater, go home. But I don't want you to ever think that the FAST equals a CT scan. Next, FAST is a data point. You have your history, your physical, your patient in front of you. You perform your FAST, you interpret it, you integrate it, and then you decide where it falls in terms of your patient care and what your next steps are. Finally, it's for sure. Ultrasound in the FAST exam decreases the time to definitive management, whether that is to the operating room and the CT scan, specifically in our unstable patients. If you want to hear more, I'm a big fan of podcasts. I'm a big fan of the TPA, the POCUS Atlas. I'm also a big fan of podcasts. So Mike and Matt really started Ultrasound Podcast, and they did ones that helped me inform this lecture. The FAST exam is often the first ultrasound exam we teach, but is it useful? And in this discussion, Jacob and Mike talk a lot about how often they're actually performing the fast now versus when they first started, and where does it fall in terms of their decision making. I'm going to stop here. I do have some interesting videos that we can review. We have a little bit of time. But before that, can I answer any questions about the FAST exam and where we are now in 2019?
You said that Trendelenburg a little bit increases the sensitivity. Does it affect specificity?
Well, it would affect, it would increase sensitivity. I haven't seen the numbers in terms of specificity. The original papers talked about cadavers, and they would instill IV fluids and see at what point they would see the stripe. You know, when sensitivity goes up, in these cases, the specificity would too, but I was thinking like if your specificity, if you're already true positive, then you'd stop anyway. It's more focused on the sensitivity. Yeah. Any other questions?
Can you talk a little bit more about the protocols people are using for contrast?
So we're not doing them at Jefferson, and I only read about it, and definitely we had Aaron come speak to us. So it's considered a very safe water-soluble agent, and they, just like they would say, give normal saline IV push. It's a similar agent that they have, and they give it, and then I don't know the exact timing of it, but once they push it, they then scan the patient, and what they found is that it's, number one, it's starting to pick up some of the solid organ injury, and we know that ultrasound is not the definitive modality for solid organ injury, but they're able to pick up the actual injuries that maybe the FAST exam wouldn't, and they would pick it up sooner. Yeah. It's very much in experimental mode, but it's the IRB protocols where it's been deemed safe is almost always radiology's on board because they're using it a lot now. Yes?
Is there any evidence of only doing FAST exams in peds traumas? You said it was not super specific, but we want to avoid skinning.
So that's a great question. So the question was, is there any evidence of basically doing a FAST only? Well, I think that's where we are in 2019, perhaps as in contrast to where we were in 2009. I think a lot of surgeons and a lot of pediatricians have felt very burned by the FAST exam, and they're like, we don't want to do it anymore, don't do it. It makes things worse. And I think, you know, there's a role for, again, it being a data point, but if your suspicion is high, the thought is that your FAST shouldn't be negative, send home. Now, we also know that the way these patients are managed is different. They should take out spleens and pack livers, et cetera, et cetera. There's so much more conservative approach, especially in kids, that there's no fast and done. It's usually fast and another imaging modality, fast and observation. I mean, if they're really unstable, it would be fast and OR, but again, it's always with the trauma surgeons. I think it's very important for us to involve trauma surgeons in these conversations and to help. It's a way to actually create sort of commitment to patient care in terms of also learning the FAST exam. And some of the places I've been, the surgeons want to learn it because they want to start billing for the FAST exam rather than have the ED pets. So sometimes it goes back to the business of it. But in general, you know, it's a part of ATLS, it's a part of patient care, and it's something they can repeat on the floor in the ICUs. But the summary is, I've not seen any protocol where it's fast and stop for kids. Yes?
With the kids, application of FAST exam, so what's the difference between a 1-year-old and a 16-year-old in the FAST specificity and sensitivity? Is there any difference there?
I've not seen specifically data on that, and the Hines article, the inclusion was 0 to, I think, 18, and we all know, like, 12 to 18 is often the size and organ maturity of an adult. So no, but I guess our suspicion, if we studied it, would be like 0 to name an age, you know, probably those lower sensitivities, but as they get older, our sensitivities probably get better. Yeah. Question back?
I just wanted to just add something. Just people with FAST exams in the state of children is like higher prevalence of false positives, especially in younger female patients. So it's one thing to take with friends.
Yeah. So I want to thank you for highlighting that. Like, what do we do when we see fluid? You know, does it mean they go stack to the OR or stack to CT? it goes back to that data point and sort of your clinical management. Is it a woman, is she on menstrual? Could there be a popped cyst? Sometimes we're seeing, in the case of, say, of a heart, we're seeing pericardial fat. Sometimes we're seeing physiologic free fluid. There's something that maybe some of you have seen called a double line sign, which is another false positive for a fast exam. You can actually see the sonic capsule and the renal capsule, and those two lines together look like these parallel lines with a little stripe in between. That's also, there have been case series on the double line sign. So just like any modality, you have to know the limitations of it, and this goes back to sort of always staying very humble about the care we're providing and not being too cavalier. Yeah. Yes?
What was the thing, I know you said it's kind of outdated now, but what was the thinking behind FAST being not useful at all for penetrating trauma versus blunt trauma?
I believe it's because when we're using a FAST, we're looking at indirect evaluation of injury. Whereas penetrating, what we're worried about is if it penetrates solid organs, the spleen, the liver, the bowel. And if you're not going to pick up fluid and say there's nothing wrong, then we're going to miss a lot of intra-abdominal injuries. I also think that people, it's just human nature that people are very resistant to change. And and if I learned that a Hohmann sign is the sign to document regarding a DVT, and we now have found like Hohmann sign is actually like it's not going to tell us much. Like if you have a suspicion of DVT, I think there's a resistance to change as well. There's a question in the back.
I'm just curious, kind of what your protocol is now for fast. We find the residents are fasting everyone these days, even our people who have very low suspicion for having any sort of intra-abdominal injury. And it's a learning experience, obviously, but then you get into issues with those false positives and what do you do with them and that sort of thing. So I was kind of curious how you run that protocol, and then also, is there any protocol who's doing the fast in your traumas? Like, sometimes the most inexperienced person is kind of grab the throat, and do you guys have any algorithms for that?
So I can tell you what I've seen, and then I can tell you sort of what I do now. I definitely have seen that everybody has their role for a trauma evaluation. So it's the PGY1 that's often doing the FAST, the FAST and the IV. And then when we've had interns rotate on trauma at Jefferson, they go to Cooper. When I was at St. Luke's Roosevelt, they would go to Miami or shock trauma. In Colorado, they would go to Denver General because I was at the University of Colorado, and they work together. They're like sister hospitals. So it depends on where I've been. It's the PGY1 or the more junior resident, because often PGY3 is airway, PGY4 is running the resuscitation. And also that usually matches, it's usually the PGY1s and 2s that have done an ultrasound rotation, so ultrasound's freshest on their minds. I think I completely respect sort of people that don't want it, because what if it tells us something we don't want to know? It's like opening up Pandora's box the way the white blood cell count can open up Pandora's box. But I also think that, just like we've navigated the white blood cell count, we can navigate ultrasound. And I think sometimes there's a big fear factor. I do think we have to be responsible, and this sort of ties into, where do we stand with doing educational studies? There are some institutions that say there's no role, I don't want you ever doing an ultrasound study, because if you don't have a gold standard with which to compare, if there's no follow-up, what if we miss a cancer? What if we miss a cyst? And I think it becomes this sort of culture of the institution, and recognizing that we are a teaching institution. So I personally am okay if an ultrasound is done on every trauma patient, even with low suspicion. Number one, for the learning, but also, and maybe this is a cop-out, trauma is so protocolized that almost everybody's getting a CAT scan. And so that may not be the practice here, but in almost every center, it's almost trauma determined, like not to miss, so they often will do a head-to-toe CT scan. That, of course, is problematic, and I think we're going to be scaling back as healthcare dollars and reimbursements continue to get scaled back. But there's a comfort if, well, we can do the FAST because they're going to get a CAT scan, and we can do. But if that is not the scenario, then I think it's, number one, ultimately the attending whose name is on the chart's preference. And number two, I think there's a role for faculty discussing it at faculty meeting and taking an organized, standardized approach with which everybody feels comfortable.
I think adding that sort of, I guess for us, what happens a lot is it's a triage tool of like, we have our critical areas and our non-critical, and sometimes people are using their FAST exam as, oh, there's the FAST is negative, they don't need non-critical to go over. I don't know if you can speak to that at all, like you're talking about the data points, it's not going with that.
There's a part of me that really this is the first time I've heard this as sort of a triage tool. There's a part of me that really likes that, just because I've now worked in 2 places where there's the equivalent of, they call it intake, triage, stable, not stable. You know, home because you need your blood pressure med refilled, fast track because you need your lip sewn, and main ED because you're septic. You know, sort of that triage. So again, like if it's been an effective triage tool, but not as a definitive decision maker, I think that can be powerful. If there have been a lot of sort of case reviews because of it, then I think the process should get evaluated as to why that is. But I mean, if it's blunt trauma, fast is negative, vital signs are okay, it seems like it's actually okay to then have them go through, you know, sort of a less urgent versus unstable, positive fast to the trauma bay. What's been the experience?
I think in general it's actually works for the most part. We identify them stable and unstable. I think the problem is when some people are missed and they're fasted and they don't get to repeat fast, right? They change from one provider to another, and so they don't get a repeat fast, or their abdominal exam isn't taken seriously enough that they get the CAT scan that they should have gotten after that fast.
I mean, maybe it sounds like this is sort of that, in terms of the sensitivity piece, you know, time 0, someone may not have fluid time, whatever, maybe they may, maybe ensuring that step of the second fast could be useful. I understand, like, there's time, there's resources, there's crowding, and everything sounds great when you're talking about it intellectually in a room, and it's very different real time when you're at the patient's bedside. Yeah. There was another? That.
Yeah, I was just going to go off what Julian asked. Remember that the fast exam is to get definitive management. If the patient has a real stab wound or a real gunshot wound to the abdomen, their definitive management is likely operative. So, you know, for example, Dr. Hirschberg does not want you to do a fast exam on a patient he's going to take to the OR environment, right? Because that might get in the way. And I think that's probably why it goes if it's like maybe it violated the peritoneum, maybe some of the surgeons will want you to do a fast exam, but if it's a real wound, really to the abdomen, they're going to take them to the OR quickly.
Yeah, so some people, some attendings may think, why are you doing this extra test? It's not going to change what we do. And I think that's a good way to think about it. The paper in Journal of Ultrasound Medicine, it was basically military in like Afghanistan. So they were sort of in a war situation and there was no CT scanner. And so they were trying to see if they saw these fluid pockets and they had what looked like a penetrating injury, then they took them for washout exploratory laparotomy. I don't want to put you on the spot, but I'm going to put you on the spot. Any thoughts about where we are with FAST and where it plays a role for you? As
I was trained with FAST, and it's part of my curriculum in critical care fellowship.
And where was that?
In University Hospital in Newark.
In Newark, yeah.
So, I trained with emergency physicians for 2 weeks, doing various ultrasounds. And obviously we do a critical care ultrasound in the ICU as well. But as far as the blunt trauma goes, of course, that's it's very useful. I personally have done maybe 4 or 5 DPLs here. Never done them as a resident, never done them as a fellow, as an attending. So maybe once a year on average. And all of them actually were done, 2 of them were done after questionable positive fast in an unstable blunt trauma patient that I decided to do a DPL to confirm it.
Yeah.
I mean, obviously there were some nuances to that. But yes, it's very useful. Obviously we're always cautious about these false positives. For example, yesterday, blunt trauma, multifocal sort of areas of examination, of bleeding, and there's a positive fast. Now, what do you do with that? Obviously the patient didn't go to the operating room. The patient had a totally negative abdominal CAT scan. So this is one of the, positive fasts. And you would say, what's the big deal? You open the abdomen and close. There are consequences to negative and non-therapeutic laparotomy. There may be, in the military, maybe there's a lower threshold for non-therapeutic and negative laparotomy because that's all you have as a diagnostic tool.
Right.
Here in a hospital, a sophisticated hospital with sophisticated imaging equipment, and what we know about the complications of non-therapeutic laparotomy, we are less happy to do that.
Yeah.
But yes, we always cautious about the false positives.
But that goes back to sort of the data point piece of really what am I seeing in front of me? When I was at the University of Colorado, which is very tertiary quaternary, they're like, oh, you're here, so when we have PE patients, you can do the ultrasound and they can go home. I was like, no. No, ultrasound is not diagnosing PEs yet. I mean, I think we're reading the literature about our huge saddle emboli that were causing right heart strain, but we walk humbly through life with our tests, with who we are as people, with being a physician, and
as far as, I'm sorry, from the penetrating trauma, the reason Dr. Hirschberg and myself also, we don't necessarily rely on that. I don't mind doing it, but even in a stable patient, a positive, fast, and penetrating trauma may not mean that much at that point in time, because there may be fluid, but maybe it's just fluid from bleeding momentum, for example, and patients remain totally soft 6 hours later,
Yep.
and we don't do a non-therapeutic or even a negative laparotomy.
Yep.
So we tend to observe them
Yep.
with physical exams.
Yep.
And some of us, including myself, we didn't do a CAT scan on the anterior abdominal stab wound in a totally stable patient without peritonitis. We just submit and observe them for 12 hours. And if they have any signs of sepsis, that means there's an injury when we operate it. If they don't, we feed them and they go home the next day. So without any CAT scan.
Yeah.
So we're hyper aware about the overutilization of CAT scan because of the healthcare dollars,
Yep.
and we do a lot of unnecessary exams.
Yep.
So some of us are trying to be more selective. So.
I found for me as an emergency physician, I felt as if I can provide the best patient care when I'm working with colleagues that have trained with emergency medicine, that have a respect for emergency medicine, and specifically with ultrasound. And when I was in Boston, emergency medicine was really trying to establish getting some respect, forget point-of-care ultrasound. And there was a surgeon that had trained in California in Bakersfield, and it's like they have an EM program. They got lots of blunt trauma off a very busy highway in California, and he was like, "I love emergency physicians," and we like hadn't heard that. And he's like, "Oh yes, you're," and it was sort of, it's all about patient care and teamwork, and sort of being on the same page. So the fact that you trained with emergency medicine with ultrasound, it makes patient care easier and better.
Do you want to show us some of the videos?
Sure. Yeah. And let's see. Okay, so I'm just going to give you a one-liner on the presenting patient. Not all of these are direct abdominal trauma or trauma-related. So the one-liner, and I want you to say to yourself what you think the diagnosis is, and then we'll actually say what the diagnosis is. So patient comes in with painless loss of vision. Patient's coming in with right lower quadrant pain, and actually it hurts. Kind of bent over. This is a true patient we saw at St. Luke's Roosevelt. Patient had been stabbed 11 years prior and never sought medical care. What? And was coming in with a headache and said, I keep noticing this pulsation in my stomach. All right, these are the diagnoses, and then we'll go through each of them. Amazing. This is the thing about ultrasound. Again, like what if we don't know? What if we have false positives? But it's sort of, the more you look at normal, you're going to pick up abnormal, and every once in a while you get these cases. So this is a retinal detachment, and many of us, the focus question for ocular ultrasound is there something in the vitreous chamber, yes or no? Yes or no? And people always call it posterior chamber, but in terms of our anatomy, if you remember, it's not the posterior chamber, this is the vitreous chamber. The posterior chamber is between sort of the angles that, I forgot all my anatomy now, but basically, it's not the anterior chamber, it's where the lens lies with our supportive ligaments of the lens, and then behind that is vitreous. So the question is there something in the vitreous, yes or no? The answer is yes. But those of us that are used to doing ultrasound are trying to actually get a little better than that. And can we actually distinguish the difference between vitreous versus retinal? Those of you that said retinal are correct. Now, how do I think of retinal? I think of retinal as, do you remember Christmas candy from the 1970s and 80s? It was like that nice ribbon candy. So to me, the retina is this thick ribbon-like hyperechoic that looks like sort of Christmas candy. Now, this image, I'm a little off axis, or the provider that did the video is a little off axis, but you should be able to trace the retina back to its connection at the optic disc. And I think of it also as seaweed sort of floating in the ocean floor.
The power just went
Power source?
Sleep mode?
Sleep mode.
It's cooling down.
I
think so.
Okay. The retina is ribbon-like and thick, and I think of it as being secured down at the optic disc, and it's like seaweed on the bottom of the ocean floor. Versus vitreous is a little bit more, they talk about it, laundry in the washing machine or socks in the dryer, and basically it stays horizontal and it swishes back and forth, back and forth. And one of the ways to start seeing this, just like for seeing a positive fast, you can start ultrasounding your liver patients. One of the best ways to see this is if you have patients with hypertension and diabetes, a lot of times they have vitreous chamber findings. And I had a patient that came in and thought that all of a sudden there was loss of vision. It turned out it had been progressive for about 6 months. And we did an ocular ultrasound, and sure enough, there was vitreous. It's much less thick, ribbon-like, and focused. It was just this swishing stuff in the vitreous.
Let's turn back on. Here it comes. All right, we're back.
Awesome. So one of the best ways for acute appendicitis, so a lot of times it's been very different depending on where I practice. Some surgeons are willing to take a patient to the OR based on our ultrasound. Some are willing to take based on a radiology ultrasound. I'm currently practicing a place that even when we have ultrasound positive, they want a CT scan. So full disclosure, when I was 12 years old, I was walking on the beach and I started having this pain in my right lower quadrant. And I thought maybe I had strained a muscle, and I was 12, which, clearly in that pre-medical mindset, that pre-medical mindset. And I had this pain, and I didn't usually complain of pain. My parents took me to the local emergency department. They drew a blood test. It must have been a CBC, and I think the white count must have been elevated, and maybe there's a shift. So what they told my parents was, you can go home, don't let her eat. So went home, went to sleep, woke up, and the next day my pain was worse. And I remember that I was walking like this, like bent over. So I had to sew a sign, and I kept saying, because I wasn't a complainer, I was like, I'm sure I'm making it up. I'm like, no, it hurts. So then I went to the pediatrician. The pediatrician examined me, sent me to the emergency department. It's a small town, everybody knew everybody, and it was right next door. And based on my examination and the white blood cell count from the night before, they took me to the OR for my appendicitis. So it's amazing then once you get a medical knowledge, you're like, that's what I had. I had a sew sign. And it hurt to stand up. So one of the best ways to start getting good at appy ultrasounds is when your CTs are positive, go use an ultrasound and look at those patients. And you've probably seen the videos, and if you haven't, watch some of the online learning. If you give the patient the probe and say, put this where it hurts the most, they will almost always put it right where the appendicitis is. Now, there are anatomical anchoring landmarks like the psoas muscle, the internal iliacs, and the peritoneal reflection. And what we're seeing here is there is the peritoneal reflection right here. And often an inflamed appendix, unless it's retrocecal, will be, you're not seeing what I'm seeing. You can see it now.
It's on a separate screen.
Oh. And if we don't see it, yeah. So, peritoneal reflection. This is your inflamed appendix. How many of you know what vermicelli is? It's a kind of pasta. It stands for worms, so the vermiform appendix is the word. I love etymologies and words. So this is our appendix, and you can actually see